Hello, I'm Dr. Steve Kariya, and welcome to Housecall. Tonight we're talking about updates in cardiology 2026 with the distinguished cardiologist Dr. Peter Sabia. So, welcome back. February is Heart Month. Prevention of heart disease is better than treatment. Dr. Sabia, can you please tell me a little bit about your background and also then about some risk factors for coronary artery disease?
Sure, I'd love to. Thank you for inviting me here. I did my medical training, my medical school at University of Maryland. My other training was for my residency and cardiology fellowship at University of Virginia. After that, I came to private practice here in Silver Spring, Kensington area in 1990, and I've been in private practice since then. I've practiced in pretty much all of the local hospitals. Presently, predominantly at Holy Cross Silver Spring in Germantown. I'm the chief of cardiology at Holy Cross Hospital.
Wonderful.
So, as you mentioned, it is Heart Month, and risk factors are very important in terms of evaluating for coronary disease. There are kind of two sets of risk factors. There's the modifiable risk factors and the non-modifiable risk factors. The non-modifiable risk factors include age, sex, and family history. The modifiable risk factors include high blood pressure, diabetes, cholesterol, smoking, obesity, and exercise. All of the factors are important, but probably the most common and the most actionable is hypertension or high blood pressure. Hypertension is very common. People in their 50s, about 50% of those patients have hypertension. In the 80s, that goes up to about 80%. Hypertension is also important as a risk factor for heart attack, heart failure, atrial fibrillation, stroke, kidney disease, dementia, and death. So very important, not only a risk factor, but treating high blood pressure can reduce the incidence of all of those things.
So how do we define high blood pressure and how do we measure blood pressure?
Sure. Old school blood pressure measurements were with a cuff on the arm where you inflated the cuff up above systolic blood pressure, deflated it, listened with a stethoscope over the brachial artery, listening for the carot cough sounds that gave you systolic blood pressure. When they went away, it was diastolic blood pressure. Nowadays, pretty much everybody uses electronic blood pressures, and it's interesting that it measures vibrations in the arteries. And it looks for the maximal vibration, and it actually measures mean blood pressure. Systolic blood pressure and diastolic blood pressure are then determined by an algorithm in the system.
So what's the right way to measure blood pressure?
Well, to do it right takes a lot of work. Most of what we do is do it wrong, both for doctors and for patients. Patients rushing into our office, jumping up on the table, getting their blood pressure measured is not correct. Getting a call at 2 o'clock in the morning from somebody who took their blood pressure, that's not the right time to take blood pressure. To really do it correctly, there are a couple steps. First of all, you shouldn't smoke, drink coffee, or exercise within 30 minutes of doing that. You should have an empty bladder. You should be in a comfortable room where the temperature is good, you're sitting, your arm is at heart level. Probably one of the most important things is you should have the right size cuff. If you have a cuff that is too big, it will underestimate blood pressure. If it's too small, overestimate blood pressure. Finally, you shouldn't be talking or looking at your cell phone when you're getting your blood pressure measured. And lastly, you should take the blood pressure once or twice a couple minutes apart and average them.
If we measure blood pressure correctly, what are our goals currently?
Well, you mentioned there are new guidelines for high blood pressure. And in 2025, they set up the new guidelines. The ideal blood pressure is 120/80 or less. Elevated blood pressure is considered 121 to 129 over less than 80. Stage 1 hypertension is 130/139 over 80 to 90, and class 2 or stage 2 hypertension is greater than 140/90.
Those are a big change from when you and I trained, I think.
Oh yes, definitely. They're much more aggressive now.
And does that pay off for patient outcomes? And what is the medical approach then for high blood pressure?
Well, for people that have ideal blood pressure, you can kind of pat them on the back, say, congratulations, keep doing the things that you're doing. If their blood pressure is in the elevated range, I think you can still congratulate them, tell them to work a little bit harder on their risk factors. If people are in stage 1 hypertension, that's the 130 to 139 over 80 to 90. If they have coronary disease, kidney disease, diabetes, or a 10-year cardiac risk score greater than 7.5%, they should be treated with medical therapy. If they are in stage 2, over 140/90, they clearly should be treated with medical therapy, and the recommendation is to start them on 2 drugs.
What are the best drugs to use for high blood pressure?
Sure. The recommendations are calcium channel blockers. There's 4 drugs. First one is calcium channel blockers, very common, amlodipine, nifedipine, and that class of drugs. The second is thiazide diuretics, hydrochlorothiazide, chlorthalidone. ACE inhibitors and ARBs are the other 2 classes. I think it's important to recognize that we all thought about using beta blockers for high blood pressure, and now that's not recommended as a first-line therapy.
What if the blood pressure is not a goal after you start therapy?
Yeah, well, that's a very common thing. If we look at across all subgroups of people, of the people that are recognized with high blood pressure and treated, only about 30 to 40% of people actually get to goals. So it is a big problem. The first thing is to look for compliance, all right? Are they taking their meds? If they're not taking their meds, you don't want to keep giving them more meds. And then asking them why they aren't compliant. Is it because of cost or is it because of side effects? Secondly, looking at alternative or over-the-counter medicines that they're taking, particularly if they are taking non-steroidal anti-inflammatories, that's Advil, ibuprofen. Third, do they have other medicines that they are taking that's called the prescription medicines that are making their blood pressures go up? Steroids are a most common one. And I think a forgotten thing is a lot of people will get injections in their knees or in their hips, and they forget that that's a steroid that can raise their blood pressure. Alcohol and drugs, and then probably one of your favorites, sleep apnea, is also a significant factor to look for people that aren't controlled.
What do you do about white coat hypertension?
Well, that's a challenge. Just as we talked about, there are guidelines that we want to treat patients for. We don't want to over-treat patients. And so very frequently, they'll come in and have a high blood pressure in our office, but they always say, at home, my blood pressure is always normal. So it's important to recognize that. I always ask them to bring their cuffs into the office so we can correlate them with our cuff to make sure that their blood pressures are correct. The other problem with this is a data problem. When you ask patients to check their blood pressure at home, they usually return the next time with 17 pages of blood pressure recordings, with 5 of them circled in red with exclamation points. And you have to teach the patient that what we want to do is look at the average blood pressure and treat accordingly.
Anything else about high blood pressure that we need to know, because it's such an important risk factor for coronary artery disease?
Yeah, definitely it is. I think in the guidelines there were two things that struck me as things that we're not commonly aware of. And the first thing is with a patient with a stroke, with an acute stroke. The reflex is to try and lower their blood pressure and to get it down to 120/80. That's the wrong thing to do. You don't want to lower their blood pressure lower than 140/80 because that can lead to decreased brain perfusion and actually can make strokes worse. So we don't want to do that. We want to keep that permissive hypertension in that. That was one of the important factors. The other thing that I think a lot of us deal with is the patient that calls us again in the middle of the night with a blood pressure of 180/105. And what should I do? That's not hypertensive emergency. A hypertensive emergency is an elevated blood pressure with symptoms. So that's chest pain, shortness of breath, or neurologic symptoms. Those are the patients that need to be told, go to the emergency room and get treated. The other patients without those symptoms, have them come in the next day or within a couple days, and you can adjust their medicines as an outpatient.
We only have a couple of minutes before we have to take our break. Tell me a little bit about how we detect coronary artery disease these days, because I think that is also a changing background and workup these days.
Absolutely. So we talked about the risk factors, but really the issue is, do the risk factors cause coronary disease? And we have done catheterizations where we put a tube in through the radial artery, take pictures of the coronary arteries to look for blockage. We do stress tests to look for advanced coronary disease. But really, what we'd like to do is to diagnose coronary disease earlier in its natural history so that we can treat that.
And how is that done?
One of the more common ways that we do it now is with a coronary calcium score. A lot of people are getting them. A lot of people are coming to the office with them already. It is a non-contrast, low radiation, gated CT of the chest, of the coronary arteries. And from this, we can determine whether there is calcified plaque. There's two types of plaque in the coronaries. There's the soft plaque or lipid-laden plaque, which is actually the most vulnerable. And then there is the calcified plaque, which is what a coronary calcium score identifies and localizes. And based on that, we can assess the degree of plaque and the patient's risks.
So we're going to get into some of the ways that we're detecting both calcified and non-calcified coronary artery disease, I think, right after our break. We're going to take a very short break. Please join us when we get back, when we return with Dr. Peter Sabia, our cardiologist, who's going to talk about updates in cardiology.
Hi, I'm Ryan Blaney, a third-generation race car driver, and we dedicate a lot of our time to going as fast as possible. My grandpa Lou is the reason why my dad and I started racing, and I'm really proud to follow in his tracks. But when my grandpa was diagnosed with Alzheimer's, it was a very unexpected bump in the road for us. I've learned a lot on this journey with my grandpa Lou, and the memories of my grandpa will always be with me. And in our family, we're used to getting involved, and I encourage you to do the same, especially when it comes to caring for your loved ones. When I think about Alzheimer's and the impact it had on my family, I recognize that losing a race isn't such a bad day after all. It's important to notice if older family members are acting differently, experiencing problems with their memory, or having trouble with routine tasks. Talking about Alzheimer's can be really tough, but if you notice something, have a conversation with your loved one. Encourage them to see a doctor or offer to go with them. Early detection of Alzheimer's can give your family time to explore support services, make a plan for the future, and access available treatments. If you or your family are noticing changes, it could be Alzheimer's. Talk about seeing a doctor together.
Welcome back. I'm Dr. Steve Kariya. Welcome to Housecall. I'm here tonight with Dr. Peter Sabia, cardiologist, talking about updates in cardiology 2026. Peter, we had left this talking about some of the calcium scoring tests and some of the screening tests for coronary artery disease. So people get these tests and they look at the numbers and they don't know what the numbers mean. What is the significance of some of these scores?
Sure. The calcium scores are very helpful in looking for the amount of calcified plaque. What the CAT scan does is it measures the area and the density of calcium in the arteries, and then it generates a score.
In the coronary arteries?
In the coronary arteries, yes. It can identify calcium in the aortic valve and then in the aorta itself, but what we're focusing on is that in the coronary arteries. And you're given a score based on that. So a score of 0 is ideal, no calcified plaque. A score of 1 to 99 is considered low risk, good. A score of 100 to 300 is considered intermediate, and a score of greater than 300 is high.
And are these age adjusted?
The scores themselves are not age adjusted, but there is a number, a percentage that's given with the scores themselves that tells you where you fit in terms of age and sex adjusted. The only problem with that is that patients see a 76% number on there and they get worried, do I have a 76% blockage? No, it's where you sit in the population.
Okay. And then once you get this score back, assuming patients are going to coordinate with their physician, of course, how does the score affect the treatment decisions?
So if you have a score of 0, again, congratulations. Keep on doing what you're doing. Keep working on those risk factors. If your score is 1 to 99, good, not so, but a little work.
Not perfect.
Not perfect. A little more work can be done on it, but not necessarily needing medical therapy. You can talk to your patient and decide whether they would want to or not. If they're younger, they may want to. If they're in their 70s or 80s, maybe not. Once you get over 100, then you have to start thinking about therapy. And I recommend lifestyle modification and starting them on a statin. Once they get over 300, then a statin and aspirin are considered therapy for that. The other thing that I also recommend is a stress test for them, because what the calcium score is looking at is plaque, possibly non-obstructive. What we want to know is, do they have blockages there? The other thing to recognize is just because you have a high score doesn't mean that you have severe blockages or that you need a catheterization.
But it does mean that you probably need to see your physician, if not a cardiologist like yourself.
Oh, absolutely.
For risk assessment.
Absolutely. You need some work.
Before you actually have a heart attack.
Correct.
So are there changes in management that you have seen in the last several years with regard to the implementation of these calcium scores and how you're managing patients?
Well, other than the changing in drug management, the increase in use of aspirin, since aspirin is not recommended for all people, but only people with coronary disease. If they have a high calcium score, that is considered a coronary disease equivalent, so they should be on aspirin, and they should be started on a statin. There has been a lot of effort to try and push the LDL lower, even in people that have no active coronary disease but high calcium scores, getting their LDL below 70.
Calcium scores are often used to assess stable patients. Mm-hmm. Can you tell me a little bit about the changes with regard to new treatment recommendations for patients with acute coronary syndrome or a heart attack, also known as a myocardial infarction?
Sure, there are new guidelines that also came out in 2025. They've modified that so that they've put STEMIs, non-STEMIs, and unstable
STEMIs are?
ST elevation myocardial infarctions. So they've put in all these together since their treatments are basically the same medically. The only difference is their initial treatment. In STEMIs or ST elevation myocardial infarction due to a clot and occlusion of the coronary arteries, The recommendations are still for prompt revascularization with a stent or balloon. For non-STEMIs, which are subtotally clotted arteries with positive troponins, it's recommended that they have a catheterization within 24 hours.
Antiplatelet therapy is standard treatment for treating acute coronary syndrome. What are the new recommendations regarding how long we treat patients with these basically blood thinning therapies?
Yes, the recommendations are changing. They're trying to get to shorter durations of them. Still the recommendation is for 12 months, but in patients that are at high bleeding risk, instead of dual antiplatelet therapy, which is aspirin and a P2Y12 inhibitor like Plavix or Brilinta or Prasugrel, it's being recommended that after 1 month you can stop the aspirin and just continue the other agent.
How aggressively should we be treating all of these patients or cholesterol levels after a heart attack?
Well, as I kind of mentioned in the coronary calcium score, the recommendations are for more aggressive treatment. So anybody that has an acute coronary event, ST elevation infarction or a non-acute, they should have their LDLs below 70. So if they are not on maximal statin therapy, they should be put on maximal statin therapy. If they are on maximal statin therapy and not below 70, they should be put on another agent, ezetimibe or Zetia, bempedoic acid, Repatha, one of those other agents. Some people have even recommended that we aim for an LDL below 50, and a lot of the European guidelines recommend that.
Is that achievable for most of our patients?
Is it achievable? It is achievable. It takes some work. It does take it may take multiple drugs to do that, and it takes a combination of 2, maybe 3 drugs to get there.
How aggressively should we be treating people with anti-inflammatory therapy with all of the talk about inflammation playing a role in the evolution of coronary artery disease?
Well, you're right. There seems to be 2 complementary parts to atherosclerosis. There's the lipid component, the cholesterol component, and then there's this inflammatory component. There seems to be an unrecognized or uncorrectable part of coronary disease that is related to inflammation. People have tried to work on that. There was a trial about 15 years ago called the CANTOS trial, where they gave an intravenous drug that blocked interleukin and showed a reduction, 15% in events. More recently, people have tried colchicine, a drug for gout, because it's cheaper, oral, easily taken, reasonably well tolerated.
And prevents gout.
And prevents gout. And 2 of the trials, the Ledoco and the Colcott, showed up to 31% reduction in events, which is pretty remarkable. A more recent study looking at the ST elevation group, 7,000 patient study that treated patients with colchicine after stenting, unfortunately did not show a benefit. So the jury is still out about that.
So it's not standard therapy, but it is intriguing in terms of
it's intriguing and consideration.
Are there other anti-inflammatory therapies that are being studied in these large trials?
There are some others, but none really have gotten to clinical practice.
Of course, aspirin is
I should have meant thank you. Yes, aspirin, beside being an antiplatelet agent, certainly is an anti-inflammatory agent. So maybe there's something for that too.
And we've known for a long time that inflammation in other parts of the body can also cause heart attacks, because we've known for a long time that pneumonia patients have a higher incidence of cardiovascular disease, both stroke and heart attacks, for a very long period of time.
And also people with inflammatory arthritis have higher association of heart attacks.
Okay, let's switch gears a little bit. There's been a lot of technological advances in cardiology. What are the biggest ones in your practice?
Well, since 1990, a lot of things have changed. We have stents, we have ICDs, we have...
I'm sorry, ICDs are...
internal cardiac defibrillator for people with ventricular tachycardia. We have left ventricular assist devices, which are pumps for people with heart failure. We've also had atrial fib ablations, which are catheter-based procedures to treat atrial fibrillation. But for me, I think right now the biggest factor, or the biggest important factor for my patients is TAVRs.
And what is TAVR?
TAVR is transcatheter aortic valve replacement. And what that is a percutaneous, it's done through the groin, through the skin, without a surgical incision. And we crimp a valve, we squish a valve onto the edge of the balloon. The balloon is then advanced up across the aortic valve and then inflated, and a valve is then left in position without having to have surgery.
Now, in the old days, we remember when people would have their sternum cut, chest spread, heart stopped, go on cardiopulmonary bypass, have to take out the old valve, put in the new valve. Patients would be in the hospital for at least a week. What's the downtime for this new procedure?
Well, you're right. Before 2005, that was the only option, was surgery. With this, with a TAVR procedure, pretty much they go home the next day. It is a very, I shouldn't say very, but it's a relatively simple, well-tolerated procedure for the patients.
Who's considered a good candidate for this?
What we do nowadays is we have a heart team, which is a group of physicians, usually a surgeon, a structural cardiologist, someone who specializes in this, along with other members of the team, and they look at the factors of the patient. They look at their age, their fragility, other clinical factors. They look at the valve. They look at peripheral vascular disease. They look at the aortic root size, and then they decide based on that whether a patient is a candidate or not. One of the biggest factors is age, and one of the recommendations from the guidelines is that if you're over 80, you should get a TAVR. If you are 65 to 80, either one. If you're under 65, you should get surgery. Now, if you look at the patients that are under 65, about 50% of them are getting TAVRs. And that's because, why not?
What are the downsides of TAVRs then?
Well, the procedure is, again, very well tolerated, getting people out of the hospital the next day. Like any procedure, there's a risk of stroke, heart attack, and death, but those are very low. The biggest risks are when we put the valve in, it may not fit in perfectly, and there can be some leakiness around the valve. We can also get conduction system problems, electrical problems, where the patient would need a pacemaker. The biggest thing is longevity, and this has been the real question about it. How long do these valves last? They look now like they're lasting 10 years, so that's pretty good. Particularly if you put that in an 80-year-old, that's going to last them most of their life. Put it in a 50-year-old, you're going to be facing some problems down the road.
Well, Peter, thank you so much. This has been a wonderful synopsis of updates in cardiology. There's been an awful lot of learning that I have done, and I hope our listeners and viewers will also learn. So I want to thank very much my guest, Dr. Peter Sabia. Thank you, our viewers, for tuning in. Please join us next time for another edition of Housecall.